Hello, everyone, and thank you for joining us today for the February Research Seminar Series. I'm Renima, a Program Assistant for the BC Brain Wellness Program, and I'm thrilled to be your MC for this online gathering. Today, we have the honor of hosting a distinguished guest, Dr. Mark Carpenter, who will be shedding light on a fascinating topic. In his upcoming presentation titled Standing Up to Our Fear, Understanding the Links Between Emotion, Balance, and Falls, Dr. Carpenter will share insights into how emotions like fear and anxiety directly impact balance, instability, dizziness, and the risk of falls. Before we get started, I'd like to first acknowledge that the BC Brain Wellness Program at the Jahavid Mofagan Center for Brain Health is situated on the traditional, ancestral, and unceded territories of the Musqueam people. I'm joining you today from Vancouver, the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. As all of you are joining from different nations, I encourage you all to take a moment to reflect and give thanks to the land on which we are privileged to work, learn, and play from. I would also like to take a moment to thank all of our program donors for supporting the BC Brain Wellness Program. Because of your generosity, we are able to provide these educational events and our online classes. As an entirely donor-funded program, we really rely on your generosity to ensure the continuation and development of our program. Thank you for your ongoing support. A couple of housekeeping notes before we begin. If you have any questions for our presenter today, we will be having a Q&A session after Dr. Carpenter's talk, where you'll get the chance to ask any questions in front of the other audience, or there will be an opportunity for you to perhaps directly ask him questions in the chat or raise your hand. For anyone that's joining on Zoom, please type your questions in the chat box and we'll answer them towards the end of the Q&A session. To keep everything streamlined, only the presenters and MC will be unmuted for today's session on Zoom. As well, the session is being recorded and the recording will be available to you on our website at bcbrainwellness.ca in about 2 weeks, if you would like to rewatch or share with your friends and family. Without further ado, it is with great pleasure that I announce our distinguished guest speaker for today's research seminar series, Dr. Mark Carpenter. Dr. Mark Carpenter stands at the forefront of groundbreaking research in the field of kinesiology, holding the esteemed position of professor at the University of British Columbia. With an illustrious career marked by academic excellence and innovative exploration, Dr. Carpenter serves as the Director of Neurocontrol of Posture and Movement Laboratory. In addition to his role as a professor and laboratory director, he also assumes a leadership position as co-lead of the Origins of Balance Deficits and Falls Research Cluster at UBC. Without further delay, let's welcome Dr. Mark Carpenter to the virtual stage. Dr. Carpenter, the floor is yours.
Great, thank you very much, and thank you for that wonderful introduction. And I'd like to thank the Brain Wellness Program for inviting me to speak today. It's a really exciting opportunity to be able to talk about a topic that I've been studying for over 20 years, and a chance to share some of the research that's come out of my own lab and other leaders in the field. Before I begin, I just want to start by acknowledging that I am very grateful and for being able to live and work on the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people. So we know that falls are a significant health risk in Canada. So for Canadian seniors, about 20 to 30% suffer a fall each year, and the rates of falls are increasing year over year. There's higher rates of falls in older women, and it is currently the leading cause of injury-related hospitalizations in Canada. So a significant problem. Now, there's multiple factors that are known to contribute to falls, and one that's starting to gain more interest in understanding is concerns about falling or fear of falling. Now, that was reflected in a more recent World Guidelines for Falls Prevention that was just published in 2022, where one of the strong recommendations of those guidelines, which was a global initiative, was to include the evaluation of concerns about falling in a multifactorial fall risk assessment. Now, the reason for that is that there's strong evidence that concerns about falling is predictive of future falls. Now, to define a concern about falling, this is a lasting feeling of dread or apprehension about situations that are believed to be threatening or challenge balance. Now, I just want to comment that concerns about falling as a term is closely related to fear of falling, which is more commonly referred to in the literature. Concerns about falling are now recommended as the term to be used because it may carry less stigma, being considered a less intense and emotional form of fear of falling, and possibly to avoid being inappropriately linked to more psychiatric conditions. However, in the literature, fear of falling is used more commonly, and so we'll use fear of falling as the broader umbrella term for the purpose of my presentation. So why study fear of falling? Well, there's high levels of fear of falling reported in older adults. About 50% of those older adults who have previously had a fall report having a fear of falling. And more than 30% of those that have never fallen also report having a fear of falling. So this is a very common issue that faces many older adults. There's also higher rates of fear of falling reported in individuals with balance disorders. So that includes individuals that have vestibular loss, Parkinson's disease, stroke, multiple sclerosis, spinal cord injury, just to name a few where there's evidence of high rates of fear of falling. There's also a high comorbidity observed between anxiety and dizziness and vertigo and vestibular balance disorders. And these are often presenting simultaneously with anxiety and these balance and dizziness issues at the same time. There's a number of factors that have been identified as associated with fear of falling in older adults. This includes advanced aging and frailty, a history of prior falls, existence of anxiety and depression, medication use that includes hypertensives, antidepressants, or sleep medications, and other medical conditions, including balance and gait disorders, or poor functional status and visual problems. So all of these things have been associated with reports of fear of falling. Now, there's a number of really critical impacts of fear of falling in older adults. Fear of falling is associated with decreased balance confidence, with restricted activity, social isolation and depression, decreased quality of life, poor balance control, and most importantly, an increased fall risk. So those that report having a fear of falling are 50% more likely to fall in the future than those that do not report a fear of falling. Now, fear and anxiety and stress have also been associated with increased motor deficits in balance disorders such as Parkinson's disease. So evidence suggests that those with Parkinson's disease under stressful or anxious conditions will have worsening symptoms of tremor, greater motor symptom severity, including bradykinesia. There are changes in their gait and greater evidence of freezing of gait, and there's significant postural instability associated with anxiety in PD. Now, our evidence of the relationship between balance control and fear and anxiety is built primarily on studies that compare groups of individuals that report having a fear of falling and compared to another group which does not report a fear of falling. So there's a broad range of studies that have shown significant results that there's altered balance control in older adults that are fearful compared to those that are non-fearful. And this spans a wide spectrum of different balance tasks. There's also strong evidence that there's altered balance control in Parkinson's disease patients that are fearful compared to those that report being non-fearful. Balance control differences have been identified in individuals that report having high trait anxiety, so being highly anxious in everyday life, and also individuals that have acrophobia, which is a fear of heights, or panic disorder. So they have different balance performance than those that do not have these types of anxiety traits or conditions. Now, the problem with this research is that we can't identify the direction of the relationship, right? What's the chicken and what's the egg here? So are people more fearful because they have existing balance problems, or do they have balance problems, and then that leads to becoming fearful. So what is the relationship between these two things? Now, classically, the relationship that's thought to be between fear and anxiety and balance deficits is a vicious circle, which usually starts with a fall or a near fall event. And the idea is that once you have a fall, you develop a fear of falling. This leads to activity avoidance. After avoiding activities, there's decreased physical activity and immobility. This leads to deterioration of muscle function, flexibility, etc. And because of that, there is now decreased balance control that leads to future falls. So there's this vicious circle that continues to go around and around. Now, what we're interested in, and more recent evidence suggests, is that there may be a direct relationship between fear of falling and balance control. Now, you may be able to relate to this yourself, that fear can directly influence your balance. And the best analogy that I can come up with is if we take a beam and we put it on the floor and we ask people to walk along that beam, usually they'll have no problem walking a short distance on that beam. Now, if we take the beam and we now raise it high up in the air, then what happens is most people lose their balance and fall off. Now, the actual task has not changed at all. The beam is the same size. There's no other physical constraints. The only thing that's changed is the anxiety and fear and this consequence of failure. And so if we take that analogy, and you can also see this in multiple different examples throughout your life, if the one perfect one, if you go online, and you can see some great evidence of virtual reality where we have people that are placed high up on these virtual towers, and they're asked to walk out on a plank to save this kitten that you can see here. And you can clearly see significant changes in the way that people would normally walk or stand because of this strong sense of fear and anxiety about the condition. So we know that fear can directly influence the way that we move and the way that we balance. So what we try to do then is use that as a manipulation to see how fear and anxiety may influence balance control in a more controlled laboratory setting. Now, some of the important terms that I just want to define initially is we have state fear. Now, this is a fear about a specific context. So it's an intense emotional response triggered by an immediate, real, or perceived threat. And this will involve a physiological and behavioral response to try to avoid or escape this imminent danger. It's similar to the fight or flight response that we see in extremely fearful conditions. Now, state anxiety is more of an unpleasant state of uneasiness or concern to a non-specific threat. And anxiety has physical components, so maybe feeling your skin sweating or your heart racing, and it also has cognitive elements to it, so worrisome thoughts and influence on concentration, for example. And there are scenarios where you can be anxious, and if it gets to a scenario where that threat is now immediate and real, it can have a fear component as well. Now, confidence or efficacy is our perceived capability to successfully perform a task. And so confidence is forward projecting. We're thinking about how well we think we can do something in the future. And finally, arousal is a state of excitement that involves a physiological response. And we can be aroused by things that are both negative and positive, as well as physical activity. So it's the general physiological excitement in the nervous system. Now, all of these different factors are related to one another, but they are distinct constructs, and we tend to try to measure them specifically to see how our different manipulations within the lab change fear, anxiety, confidence, and arousal, and often providing converging evidence that a person has a strong emotional response to a specific context. Now, the way that we tend to study fear and anxiety and their effects on balance is to use this height paradigm that we talked about with walking on a beam within the lab. So, for example, we'd have subjects stand on elevated surfaces. This is an example of someone that's standing on a platform that can be raised to 1.6 meters in the air, so about head height. And then we can see how does balance change within that individual when they're performing that task down on the ground compared to when they're raised up at this height and have an increased level of fear or anxiety. So we can see the changes immediately within the same individual. Now, when I moved to UBC, I got a bigger lab with a higher ceiling, so I was able to get a higher platform. And so now we can raise individuals high up to a virtual cliff, if you will, standing about 3.2 meters in the air. And we can measure, again, their balance responses and their anxiety and fear responses under these high threat conditions compared to when they're standing down on the ground in a low threat or no threat condition. Now, we also can use virtual reality to put individuals in virtual environments, such as a virtual height, that can exceed the physical limits of the lab or allow people to be in a safer scenario physically, but project them in a virtual world where they may be high up in a tower or under other circumstances that can manipulate their fear or anxiety. So think about standing on a virtual icy surface, for example. And we've done some research to show that individuals, when they're going from a low threat condition, standing down on the ground, compared to a high threat condition, so high up on these platforms, do have significant increase in their self-reported fear and their self-reported anxiety. And what's interesting is we've seen that we get similar reports of increased anxiety and fear when people stand in virtual heights, similar to real heights. So we can really drive the same emotional response in a virtual setting and a real setting. Now, early work has shown that fear and anxiety can influence performance on typical clinical balance measures. So the work I'm presenting here was done by Hauck et al. In 2008. We had young individuals performing common balance tasks low on the ground, and then when they're standing on a platform, 1.6 meters in the air. And just looking at basic clinical outcome measures that would be used to assess balance, we can see, for example, that young adults standing on a high platform, so a high anxiety condition, have a decreased performance in one-legged stance. So this is just measured as the time they can stand on one leg, and it's decreased about 12% when they are in that anxious condition. Similarly, if we look at things like maximum reach or forward leaning, there's about a 10% decrease in the forward lean of individuals when they are in a high threat condition compared to a low threat condition. And just simple performance on tasks like rising up on the toes, what we see is a greater percentage of failures or inability to do the task when people are performing it under high threat conditions. So fear and anxiety likely influences your performance on these typical balance tasks. Now, we can look more objectively at balance by using something called posturography, which provides measurable recordings of performance during different types of balance. These could include static balance or dynamic balance. Now, static balance is recorded while you're standing still with your feet together. And even though you're trying to stand still or quietly, we know that you still have a certain amount of sway that occurs. The sway gets larger if you close your eyes, for example, and you sway both in the forward and backward direction and left and right or medial-lateral direction. Not to the same extent of this happy person here in the video, but we do have small amounts of sway that occur even though we're trying to stand as still as possible. So that's called static balance. And then we have dynamic balance where we're measuring reactions to unexpected balance disturbances. So that could be a push or it could be a movement of the support surface on which we stand. We'll talk about evidence in both of these areas. So static posturography, as I mentioned, is recorded while people are standing still. Now, the way that we measure that sway is often to use what's called a force plate, where we can see underneath this person's feet. It's kind of a fancy weigh scale, which allows us to record the pressures that are underneath the feet as the person is swaying forwards, backwards, left, and right. So we can calculate, for example, a center of all the pressures underneath your feet that's recorded with this force plate, and we can see how that central point of pressure changes during your standing task. Now, this is an example of the output that we would receive from that force plate and that center of pressure that's recorded underneath your feet. And if you were standing for a long period of time, you would see that that center of pressure would migrate around or sway around in a situation like this, both forward and backward and left and right. We call that a spaghetti plot or a stabilogram. We can measure the overall amplitude of the sway from that overall recording, or we could separate it into its forward backward direction or anterior posterior direction and its medial lateral direction, and then look at the sway behavior in those different planes. And from those, we get different measurements. So we can record the overall amplitude of that sway, whether I sway larger or smaller over the period of time. We can see whether that sway is shifted backwards and the mean or central position is in a more forward position under the foot or behind back in the foot. Or we can look at the frequency of sway or the speed of the sway over time. And we use these metrics to make comparisons during different tasks and conditions or between different groups. So this is an example of one of those center of pressure measurements that's recorded from an individual when they're standing down on the ground, so a low threat condition, which is in black, and the same individual when they're raised 1.6 meters in the air and they're in a more high anxious condition, shown in red. And so we can see there are some distinct differences in their sway pattern under these two standing conditions. The first is that you notice that their sway position, the overall central part of that sway, is shifted backwards away from the edge. There's a backward movement of the mean position of the center of pressure. Also note that that overall sway amplitude is smaller in the high condition compared to the low condition. And if we measured the speed or the frequency of those movements, we would see that there's a higher frequency or a higher speed of sway under the high threat condition. So if we look at that across the whole groups, we see that on average, the amplitude of the sway measured from the force plate is significantly smaller when people are under high anxiety and threat conditions compared to the low threat condition. And conversely, the speed or the frequency of that sway is significantly higher when they're in the high threat condition. Now, if we think about people swaying like an inverted pendulum, with their body being stiff and they sway around their ankle joint, if they sway with a smaller amplitude and a higher frequency, we consider that to be a stiffer system. And in fact, evidence suggests that you do stiffen up into these high threat conditions and sway with a smaller range, but at a higher frequency. So we call this a stiffening strategy. And this is used in healthy young adults under these threatening conditions. And multiple studies have repeated the same evidence in older adults standing under high threat compared to low threat conditions. So across multiple studies, we see that the mean position of their sway is shifted backwards, the velocity or their frequency of sway is increased, and on average, the amplitude of their sway is decreased. We see exactly the same type of strategy used by patients with Parkinson's disease that stand on these high threat compared to low threat conditions, and individuals with vestibular loss. Now, one thing that we have noted is that the strategy that is used under these threatening conditions may depend on the overall level of fear that the individual experiences. Now, for the most part, our young adults standing on these high heights have a moderate increase in their fear and anxiety, but it's not extreme. We're only standing about 3 meters in the lab. They have a harness on. And so what we see is this typical stiffening strategy that I described. So here we have a patient that's swaying down on the ground in the light blue trace, which is at the low height. And when we raise them 3.2 meters in the air, again, their amplitude of their sway decreases and the frequency increases. Now, what we notice is in a small subset of subjects that were extremely fearful, barely could get out of the chair and go to the edge at these heights. We saw a different strategy. And in this case, at the ground level, they had a similar sway amplitude as the low fear subject. But when we put them high up on the platform, they had a larger amplitude sway. So they started to really have large displacements of their body during quiet standing in the forward-backward direction. And we noticed that again across the groups. So whereas our low fear group has this typical stiffening strategy, where compared to on the ground, they have a slight decrease in amplitude when they're standing about 8.8 meters in the air. And then when we raise them to 3.2 meters in the air, they have a significant decrease in their amplitude of sway. We have this high fear group where they do the exact opposite strategy. So now they start to sway more, even when they're standing at about a table height. And when they get to this 3.2 meter height, they really have large amplitudes of sway. So the strategy that's selected by these highly fearful subjects seems very different than that of the low fear subjects. And it may have indications that they sort of having a maladaptive or an inappropriate strategy for that scenario. Now, this has also been observed in older adults. So a study by Sterniak et al. In 2016 had older adults stand on the ground and stand them on a platform that was about 60 centimeters in the air. Now, they separated their subjects in those that were generally non-anxious and those that had a high trait anxiety, so really anxious individuals. Now, in the non-anxious group, compared to standing on the floor, when they're elevated to the level of 60 centimeters, we see this typical stiffening strategy where the amplitude of their sway decreases. Comparatively, when we have these highly anxious individuals, they do not perform this stiffening strategy. They have the same level of sway both on the ground and when they're elevated on the box. So again, more evidence that high anxiety or high fear may interfere with the strategies that are typically used under these threatening conditions. Now, we wanted to determine whether the changes in balance were related to the arousal state of somebody standing under threatening conditions, or is it just because it's a really unpleasant feeling being high up on a platform? Now, one of the ways of looking directly at the effects of arousal in comparison to feelings of unpleasantness is to use something called the International Affective Picture System. So we use this to try to determine whether arousal on its own is enough to generate changes in balance control. So we had people stand on a force plate and we showed them a series of pictures that were known to generate different emotional responses. So they can be responses that have a low arousal component, but they are either sort of positive pictures, like looking at this puppy dog, or looking sort of at somber pictures such as a graveyard. So changes in the pleasantness of the picture, but there's overall low arousal. Now, in comparison, we look at pictures that have high arousal connotation. So sporting events or sexual images that are positive feeling, and those that are highly arousing and negative feeling. So images of violence or mutilation. And we could then compare balance while these people are simply looking at pictures that are driving up and down their emotional responses. And what was really fascinating is even when they're only standing on the ground and looking at these different emotional pictures, we see changes in their balance. And we see the typical change of the stiffening strategy in individuals when they're looking at highly arousing pictures compared to low arousal pictures, independent of whether they're positive or negative feelings or emotions. So we see this increase in the frequency or speed of sway when they have a high arousal picture viewing compared to low arousal picture viewing. And conversely, we get decreases in the amplitude of the sway when they're looking at arousing pictures. So stiffening strategies induced by a pure emotional response to viewing pictures. So this confirms that we have these underlying changes that fear and anxiety can impact balance control. Now, we can also measure dynamic balance. So these are postural reactions. These reactions can occur to disturbances that we may expect. So as an outcome of our own movement. So this example here perhaps should have been expected as a balance reaction. And we can have other circumstances where our balance is disturbed by unexpected changes. So we can think about surface movements underneath our feet when we're standing on a train or a subway, or rotations of the ground as we stand on a boat or a moving dock. And we can recreate those types of balance perturbations in the lab. So for example, we have a translating platform that will move or accelerate linearly underneath your feet and mimic the kinds of accelerations that you would experience on a bus or a subway. Likewise, we can use rotating platforms that will tilt or rotate underneath your feet, creating that type of a perturbation you might experience in everyday life, and look at the balance reactions to these unexpected perturbations. Now, when we're looking at dynamic balance, different methods we use for measuring postural control, or we may measure the forces underneath your feet. We can also use motion capture systems to look at how your body is moving in space in terms of accelerations or velocities. And we can also measure muscle activity, generating these postural responses, or cortical activity for how the brain may be responding to these triggered events. Now, we have incorporated the threatening paradigm with these postural reactions in a number of studies. So some early work, we had people standing on a rotating platform that could tip or tilt underneath their feet while they're standing down at the ground level, and then when they're raised to 1.6 meters in the air. Now, we've also used virtual reality to put people in a virtual height situation while they are receiving actual perturbations to their balance. And this is an example in our lab of someone who's wearing a virtual reality system while they're standing on a translating platform. Now, what the individual views is that they're standing in a virtual lab on a virtually moving system, such as this, that they feel could move backwards and forwards at ground level. So this would be a low threat condition. And then virtually, this platform will raise them up high into the air, and they will experience the same disturbances to their balance, but now under a high threatening or fearful state. Now, we can use these types of manipulations to look at how dynamic balance changes under threatening conditions. We've seen a number of different changes to balance when people are in high threat conditions. One of the ways we can analyze this is looking at the muscle response to the onset of the perturbation. And this is an example here on the left. So this is muscle activity that's recorded from the soleus and the gastrocnemius muscles, which are your calf muscles, and a muscle up in your shoulder, which is the deltoid muscle. And we look at how these muscle reactions are triggered relative to the onset of the platform movement, which is at time 0. So what we can see is after the platform moves, very rapidly, within 100 milliseconds after the disturbance, these muscles are triggered as a postural response. Now, the gray area reflects the postural response triggered at a low height when people are standing on the ground. And the red area reflects the muscle activity of individuals that are standing virtually high up in the air. And you see distinct changes in the muscle activity just due to this threat condition. So we have larger amplitudes of muscle activity across the leg and the arm muscles. And in some cases, the muscles are triggered much earlier in time as well. This is seen at a group level. So the low conditions are shown in the black columns. The high conditions are shown in the red columns. As you can see across all of these muscles, there is a shorter onset time. So they are triggered earlier in subjects that are standing high in these threatening conditions. And at the same time, the amplitude of the muscle activity or the magnitude of the response is much larger. Now, what does this mean? Well, if we have much larger responses that happen earlier in time and muscles that might be contracting at both sides of the joint, then we generate co-contraction and a stiffening response. So this may have the outcome of causing individuals to change the way that they can respond to these perturbations. Someone who is non-fearful and has a more relaxed body will have often counter rotation of the upper body and the lower body to the perturbation, allowing them to keep the center of mass over their feet. But when we are stiff to begin with, and then when we respond to a perturbation, we have excessive muscle activity and co-contraction, then what happens is that the individual will be disturbed much greater by the same stimulus, and they'll tend to fall with the platform. So they will fall in a more sort of stiff response, like a log. So these balanced responses at a low level may be advantageous, but if they are excessive and interfering with normal balance function, they could lead to falls. There's evidence that anxiety and fear can influence other aspects of balance responses as well. So one common reaction to being perturbed is to reach out with your hands and try to grasp a rail or something that will help you maintain your balance. And there's some evidence that these grasping responses can be influenced by anxiety and stress. There's very little evidence out there, but there's one fascinating study that looked at grasping responses of individuals that were standing on a translating platform. So that once the unexpected, the platform would translate laterally, and they would reach out and try to grab onto these rails to recover their balance. They had a harness on that would help them with their balance if they were unable to stand up on their own. Now, they looked at these grasping responses under 3 different conditions. A condition where there was no other secondary cognitive tasks, that's the no task condition. A neutral condition where they had a sort of a low challenge cognitive task that they had to do while they were being perturbed. And then they had a really stressful condition, which was including a math component, because math is always stressful, and but much more challenging tasks that caused stress in the individual while they were trying to do this cognitive performance. Now, they showed nicely that when individuals were doing this more challenging cognitive task, individuals reported being more stressed compared to the neutral task and the no task. And then they compared the grasping responses of these individuals when they were performing them under these different conditions. The middle trace here represents the percentage of time that individuals used a successful grasp response to being perturbed or knocked over. And you can see when there's no cognitive task, the individuals used a grasp response 100% of the time. So it is a common response that was used by them. When they were performing a task that had some cognitive challenge but no emotional element, they did have a slight decrease in the number of times they would use a grasp response to recover balance. However, when they were stressed by the challenge, then we see a significant drop off in using this very common and effective balance response. So only about 20% of the time do individuals now use this grasp response when they're stressed. So it's interfering with the normal behavior that they would typically use to protect their balance. Now, at the same time, when there are these grasping errors, they found that the subjects lost their balance and had to be supported by the harness a much greater percentage of time when they were stressed compared to non-stressed. There's a number of other evidence of changes, for example, in gait or walking behavior. So a study by Brown et al. Showed that individuals, young and older adults, walking on a beam at ground level and when they're raised high in the air, have changes in their gait performance. Most typically, what we see is a decrease in walking speed or velocity, and there were differences between older adults and young adults. Similar types of changes have been observed in patients with Parkinson's disease. So some studies by Martins have used a virtual condition where we had subjects walking in a virtual environment where they thought they were walking on a beam down on the ground. And then, as you can see in the bottom trace, they're raised high up in the air and asked to walk across this virtual platform. What they observed in patients with Parkinson's disease is when they were elevated in this virtual height, their walking speed was much greater, decreased compared to healthy older adults. What was more interesting was looking at patients that had freezing of gait compared to non-freezers. Those that were freezers had a much higher anxiety response to this threat condition. And when they were walking across the high platform, the percentage of trials where they had an event of freezing was significantly increased, both in total time as well as the number of freezing events. So much greater freezing events triggered by this threatening condition. Other elements of walking that have been shown to be influenced by anxiety and fear is that our visual patterns change when we are fearful. So a study by Kugler et al. Showed that individuals that were height intolerant or fearful of heights, when they were asked to walk across this walkway high up on the side of a building, what they saw is that their gaze was really restricted or narrowed to a small area in front of them, compared to those that were not affected by the height, where they will look around and look ahead naturally. So we have this narrowing of gaze when we're fearful and walking. This was further demonstrated more recently by Elmers et al., which looked at older adults that had a low risk of falling compared to those that had a high risk of falling and are more likely fearful. And we looked at their walking behavior and their gaze behavior down on the ground and when they're asked to walk across a beam. What they found was low risk individuals walking on the ground tended to look far ahead. If there were objects they needed to go over or step onto, they looked well in advance at those objects. And when they reached the first object, they quickly looked ahead to the second object. When you take those low risk individuals and raise them up high on a beam, their gaze behavior changes. And it's very similar to high risk individuals at the ground. In this case, they look very close in front of them, right down in front of their feet. They fixate on the objects as they approach, and they're very slow at then looking ahead to the next object. So this makes them at risk of possibly running into objects or things that are coming up where you would normally see them if you were looking around and looking farther ahead. There's a number of different potential mechanisms that might be underlying all of these different balance and gait changes. One of them is thought to be changes in the way that we either monitor and measure sensory motor control and how that affects postural reflexes. So for example, there's different motor sensory systems that we know contribute to balance: the vestibular system, proprioceptive system that involves muscle spindles and Golgi tendon organs. Vision plays an important role in balance, as does skin receptors underneath your feet. And we've done a series of studies probing these different sensory systems that demonstrate that the reflex amplitude and gain of those responses and reflexes is changed when individuals are standing under threatening and anxious conditions compared to when they are not anxious or not threatened. And this spans a broad range of these different sensory systems. So the information we're receiving is changed when we're fearful. The way that our brain processes this information is also changed. So looking at brain recordings to stimulations at low and high heights identifies larger cortical activity to the same stimulus when we are threatened. A second contributor to balance and gait changes with threat is that there's changes in our perceived stability. And this has been shown in a number of studies. So individuals that are standing at high threat conditions report having feelings of instability. This is both in real and virtual environments. And some nice work by Castro et al. Showed that even in young individuals, those that have more reported anxiety have higher levels of subjective instability. So they just feel more unstable when they are anxious. We've tested this in the lab by having people stand quietly and try to monitor their balance performance under low and high threat conditions. And what we observed was that although we know that subjects stiffen when they're standing under threat and their amplitude of their sway decreases, they in fact report and track their sway as being larger at height than compared to on the ground. So there is this disconnect between how they feel their sway is occurring and their actual sway. We see this also in dynamic responses. So we have people standing on the platform that's continually moving that causes them to sway back and forth. And we ask them to track their sway in real time. And what we observed is compared to the same sway response on the ground, shown in black, the subjects perceive their sway to be larger when they're standing at high heights. And this is reflected in a single subject and also across the group. So we have larger sway perception when we are fearful and a disconnect from what's actually happening. Now, the third potential mechanism is associated with attention. And we've done a number of studies to probe where people are focusing their attention when they are anxious and fearful. What we see is when even young adults are threatened, they shift their attention to a number of different areas. So they attend more to movement processes, how they feel themselves moving. They think inwardly about their movements. They focus more on the threat-related stimuli. They focus on self-regulatory strategies and task objectives. And they shift their attention away from more task-irrelevant information. Now, overall, this could interfere with balance in two ways. By focusing on our own movements, we may interfere with balance control, which is more automatic. And at the same time, adding more attention to things like the stimuli themselves and our self-regulatory strategies might compete with attentional resources that are needed for maintaining our balance. So all these different mechanisms likely work together. I just quickly want to talk about some potential interventions for fear of falling and its effect on balance. There are some things that we need to recognize may have an impact on anxiety and fear and indirectly on balance. So taking a close look at medications and their potential influence on anxiety. Also, fall protection strategies like hip protectors or fall monitors not only give us protection against falls, but may increase individuals' confidence and their feeling about being able to be in control in certain circumstances that might contribute to improved balance control. Now, the other two are significant interventions that we need to consider, and these are physical activity and cognitive behavioral therapy. There is some really interesting and exciting results that is emerging for how exercise may reduce fear of falling in older adults. And in a recent meta-analysis done by Kumar et al. Looked at 30 studies that included 36 different exercise programs. These involved balance training, strength and resistance, Tai Chi, and yoga. And they saw a small to moderate reduction in fear of falling in the older adults that participated in these programs. Now, this improvement in fear of falling was seen immediately after the intervention and even extended up to about 6 months post-intervention. Now, this study didn't identify any differences in the type of exercise programs and wasn't able to look at longer-term effectiveness. A more recent number of meta-analyses and systematic reviews have looked more deeply at the types of balance and exercise programs that might have more effectiveness at reducing fear of falling. And this are 2 studies by Cruz Brink et al. And between these studies together, they looked at over 50 randomized controlled trial studies that had different interventions to try to reduce fear of falling. They saw that overall, these interventions had a small to moderate effect at reducing fear of falling. But the ones that were most effective included components about body awareness. They had meditation components, and the exercises were more holistic. So including things like Tai Chi, Pilates, and yoga. And another key feature was that they were supervised or in a community group setting. Ones that were found to be less effective were those that were individually tailored to someone's fear specifically, just motivation by a supervisor, balance exercises on their own, just self-monitoring by the individuals, written materials, and delivery of exercise at home, again, unmonitored, was really less effective at reducing fear of falling. Now, what's very exciting to me is if I look at the approach of exercise and holistic treatment, for example, used within the brain wellness program, we see a number of those key ingredients across the different classes and offerings. And so I guess this is my little plug for the brain wellness program, but I'm excited to see that all of these components that's been shown in the literature to reduce fear of falling are found within the options that are available. Using yoga combined with strength and balance, aerobic and agility exercise that will holistically improve individuals' confidence as well as their actual balance performance. And even the in-class, in-person exercises take a much more multimodal approach that incorporates a lot of these aspects, as well as that group exercise and supervised components that have shown to be more effective at improving balance and reducing fear of falling. Now, finally, the cognitive behavioral therapy has been shown to be also effective at reducing fear of falling. So a recent systematic review has shown that fear of falling can be reduced by different types of cognitive behavioral therapy when they are combined with exercise. So we see greater effects of fear of falling reductions when we have cognitive behavioral therapy combined with exercise compared to exercise alone. And a few studies that have shown that cognitive behavioral therapy alone also has an effect at reducing fear of falling. The reductions can be seen immediately after the intervention and extend 6 months and even greater than 6 months afterwards. Other elements that may be effective, again, on cognitive behavioral therapy is exposure therapy, where we can expose individuals to the same threatening condition. We've done some of this work in the lab where we take individuals at the ground level and then we expose them to a height, and then we have them stand at that height time after time after time. And what we see is with repeated exposure, young adults will increase their confidence to the same threatening condition. Their anxiety will decrease back down to baseline, and fear will decrease down to baseline. And we see parallel changes in their postural control. So adaptation to repeated exposure is a potential therapy to explore. And we've also got some preliminary evidence that you can use repeated exposure to a virtual threat that also has the same effect at reducing fear of falling over time and having a significant impact on those fear-related balance changes. Now, for the sake of time, I think I'll skip over some. I think I'll finish with this slide here. I think the key thing about treating fear of falling is we need to find the balance between fearful and becoming fearless. We don't want individuals to have too much fear, because if you have too much fear, then we may introduce maladaptive behaviors. So for example, completely avoiding circumstances or standing, or bubble wrapping ourselves and not going into situations and being active, which is so critical to our function and performance in everyday life. At the same time, we don't want to become fearless and put ourselves in circumstances where we may be beyond our capability or overestimating our capacities, because standing in these situations without any fear will mean we're not using those protective strategies that might be naturally available to us or appropriate for us to use. So as I mentioned, I think I'll skip over some of the clinical assessment elements of this. I'm happy to talk about these later. But in conclusion, emotions such as anxiety and fear can have significant impacts on balance control in both young, healthy adults and those with balance deficits. The effect of threat influences actual performance on the balance task, as well as our perceptions of balance changes. The underlying mechanisms are likely a combination of threat-related neurophysiological changes, as well as changes in perception and attentional focus. We have to account for the potential threat-related changes in balance, both in research, in the clinic, and in occupational practices. And finally, we need to continue to investigate new interventions that can improve balance and the underlying emotional factors that may contribute to falls. And with that, I'd just like to thank all of my collaborators, the broad number of graduate students that have done the most of this work, and of course, all the funding agencies that have graciously supported the research that we have done in our lab. And again, I'd like to thank the Brain Wellness Program for giving me an opportunity to speak today. And I look forward to any questions you may have. Thank you.
Thank you so much, Dr. Carpenter. I think for me personally, one of the aspects that I found really fascinating was the graph where you were showing the amplitude for people at different heights. And that difference was astonishing and just not something I've gotten the chance or the knowledge I've been exposed to. I think we want to save some time for questions, so I'll take a look through the chat to see if there's any. We have one question discussing, would you suggest discontinuation of cycling and skiing for someone that may be older, so 65?
So I think that doing the activities that you enjoy and give benefit to are important, and not to avoid them, but to make sure that you're not going sort of extending beyond situations that you have the capability to do. So absolutely, you want to continue to stay active, do the things that are important to you. We know there are such great health benefits, not only to general health, but also to balance and mobility. But recognizing that if you are extremely worried or fearful about a scenario, that you may want to change or adapt your behavior so that you're working within a range that you feel confident in. But also pushing ourselves to some extent to become more active, and which will give us a better sense of control and also be able to manage things that may cause us to feel slightly anxious. So staying within your capability, I think, is the most important thing, but not avoiding activities. As we see, what this will do is lead to future falls and lead to more fear of falling.
Sounds good. I think another question we had was related to anxiety medications, which are known to increase the risk of falls. Could this be related to untreated anxiety or to the drug itself? And how do we balance adequate treatment of anxiety with drugs versus reduced risk of falls from these drugs?
Yeah, that's a great question. And so we know that some medications that are used for other purposes will have some effects on our emotional response. And so we just need to be wary of those. I think more research needs to be done to understand how certain medications may be influencing balance because of the anxiety mechanism, as opposed to its effect on other physiological changes. And so there is evidence that particularly taking multiple medications or multi-pharmacy is a predictor of future falls. And so understanding what are the mechanisms of those different medications and how it might contribute to your balance or your anxiety is important. But a lot more research needs to be done. However, it's an important area of focus.
Sounds good. We have another really interesting question about participating in exposure vestibular therapy and wondering if there is a way to kind of get involved in research at UBC.
Absolutely. So it's exciting to hear about interest in research. If you are interested in any of the studies that we're doing, I encourage you to reach out to me. There's also wonderful research across campus looking at balance control and mobility. So looking at things like the Brain Wellness Program, where they advertise different research studies. Also, you can go to the Origins of Balance Deficits and Falls Research Cluster, where we will feature different experiments that are happening. So in terms of vestibular therapy, I'm not aware of any current studies that are going on, but I'm certainly will happy to try to put people in touch with them as they're happening. And with virtual therapy and fear responses, these are things that we're just starting to develop in the lab and hope to be able to introduce very soon.
Sounds good. I think that we can probably wrap things up. Thank you everyone for your questions. Again, just to remind everyone that this will be completely recorded and will be available on our website in around 2 weeks. It will include both the Q&A session and the actual lecture components. So you can take a look and also share it amongst your network. And thank you so much, Dr. Carpenter, for presenting. We really appreciate your talk. And also, as you can probably tell from the comments, everyone that attended is also really enlightened by what you presented today. And thank you all for joining as well. And I think we'll be wrapping up today's event.
Great. Well, thank you so much for the opportunity. And thanks for all the questions. If you'd like to post them to me later, I'm happy to follow up.